I'm going to make a presentation. I know I'm still doing the fetal heart with you, but I just want to do a quick recap on how to the approach to examining pregnant women at a very basic level. I know you guys are doing an amazing job teaching in the new staff in the fetal medicine units who are coming in. You are doing an amazing job. But I just want to remind us about the protocol for basic scanning, because sometimes I'm meeting some trainees and they seem to have jumped certain stages because, because of the questions they will be asking. So I'm thinking that maybe trainers are sort of overlooking certain issues which are very pertinent when you are training somebody how to scan. So I will take you through, hopefully I should be able to finish, because this is a just quick recap to the informed. So I will take you through this course, the basic ultrasound scan course, so that I emphasize important fundamentals that you should highlight, you should sort of make important when you are teaching the new recruits in the unit. This is a presentation we did I think 2 years ago or 3 years ago, when we were doing the meetings with the Pelvic Floor Foundation of South Africa. So first of all, basic physics of ultrasound should be known. The new recruits or the new trainees, they should be taught some basics of ultrasound physics. Then I will talk about placenta assessment, amniotic fluid assessment, and then the cervix assessment. Then there will be a video that will be demonstrating how to perform a scan. Maybe to just take you through this pre-test, just in case our new recruits are there. Are you able to identify the position of the placenta here? And also something about the placenta which may look slightly abnormal. So just make it quick. This is the placenta. If you have identified it, very good. The placenta is, of course, abnormally thick. It's measured more than 40 millimeters. Then on this image, where is the placenta? When you look at the image on the right. So the placenta, there is a bilobe placenta here, and this is the accessory lobe. This is the main part of the placenta. If you had identified this, then it should be very good. How to measure placenta? You measure the thickest part of the placenta. The other use a reference of the cord insertion, where the cord goes onto the placenta, roughly. But you need to measure the thickness of the placenta for you to identify placentalomegaly. Try to do it as centrally as possible on the placenta. Right. Let me proceed. Where is the placenta position? Image on the left and image on the right. Where is it? I know experienced scanners, it is not an issue, but I know there are some students amongst us. Where is the placenta on your body here and this one? So the placenta here is on the front. If you have identified the good, then this one is at the back. That's the placenta. That's posterior. Then ultrasound physics, a little bit of the physics. I think you have seen this kind of probes we use. You have seen the transvaginal probe. We do not use this probe because it's used mainly by people who do cardiology and other specialties, but we use this probe. I just want to talk about these two probes. This probe is probably more or less similar to the other curvilinear, which is not a 3D. This is a volume probe, a 3D probe. But the one which is not a 3D probe we use in obstetrics is thinner than this one. So what is the main difference between these two probes? The main difference is that this probe is what we call high frequency. And this frequency allows the image to be more clearer. the higher the frequency means the rate at which it can generate the ultrasound waves. So that this is why we use it for TVS, but it is limited in depth. That means if you want to look at structures which are deep in the woman's abdomen, you can't use this probe. If we are going to examine a woman who has a very huge uterine fibroid, even if you can't do TVS to try and examine that fibroid with this probe, because it will run out of depth. It cannot go far, because the higher the frequency, the shorter the distance the waves are able to travel. So this is a high frequency probe, and we use it to do transvaginal examination in our field. Others use it to do transrectal examination in other fields. Then the volume probe, it's a low frequency probe, the same with the curvilinear probe, which is not on the images here. These are low frequency probe. They are used to scan where depth is required, where you really need to send waves to a deeper level. Like in this case, you see that this baby here was almost to go up to where the baby is. The machine had to send waves to almost 15 centimeters deep. If you are scanning women of big habitus, sometimes you may have to send ultrasound waves to almost 20 to 30 centimeters deep. These probes will allow for that. This probe will not allow for it. So if you are scanning someone and you cannot see clearly, you may have to use it to reduce the frequency on the machine, because even these probes here, they have a frequency range on the machines. When you look at the machines, there is a frequency range which they operate under. These ones normally may start around 3, some start at 2.5 to almost 5, some go up to 7, these kind of probes. But the majority end around 5 there. So that means if you are scanning and the woman is a little bit on the bigger side, what do you need to do? You need to reduce the frequency so that the probe can take you deeper and see things which are way, way, way deeper. So remember this, that frequency allows you to see things which are far away. The lower the frequency, the more you can examine deeper structures. So that's the probes. But ultrasound, how does it work? Within these ultrasound machines, there are some tiny piezoelectrical crystals. However, modern machines have got this plumbium, zirconium titanate crystals, like these probes, these modern probes here. But the rest of the other probes, the older probes and most of the probes, they will have these piezoelectrical crystals, which are arranged in layers. And it is these piezoelectrical crystals that vibrate. They do vibrate when you plug your probe onto the machine. Electrical energy, when it arrives at the probe here, it will cause these crystals to vibrate. And this vibration is what produces the sound wave, which is sent into the woman's tummy. And this sound, when this sound wave is sent, when it hits objects, it is reflected back to the probe and captured by the probe. Once captured by the probe, the machine through its brains will construct an image based on the echoes that are returning or the sound wave that is returning. So when you are scanning, you are not taking photos. It's different from your phone when you take photos. What is happening when you are scanning is that the images you are seeing are a reconstruction of the returning waves or the returning echoes that we have sent using the probe. So the returning echoes are what gives us the image. So that means if there is anything that impedes the returning echoes, your image is going to be poor. If there is anything that impedes the sending of sound waves, you are not going to see anything. Like if there is bone here, let's assume there is bone there. You're not going to see anything. It's going to be dark because the bone is not going to allow the waves to pass through. All you are going to experience darkness behind it. And you see the bone reflecting, because every wave which is hitting the bone is going to be reflected backwards. But behind it, you are not going to see much, because most waves are not able to pass through it. I'm talking about ossified bone, not fetal bone. Fetal bone is not 100% ossified. This is why it allows some ultrasound scan waves to pass through. So then how does the machine distinguish between the, you can see some images are darker, some are brighter. The more echo dense the structure is, the more the waves which are reflected back to the machine. That means if there isn't some impediment to the transmission of the waves, the machine is going to, the image is going to be more gray or more white. So this is why you see that bone is more defined than soft tissue. Where there's fluid, there's no returning echo here. So it appears dark because all the waves are passing through. There's no bumping and reflection which is happening at the level of the fluid. This is why the fluid is always dark, right? So this is how the images are produced. It is important to know how the images are produced. So placenta location, why do we have to do placenta location? We can do it as part of routine exam. We can also do it to check the position of the placenta in relation to the cervix. We can also do it in the context of emergency situations like antepartum hemorrhage, and also in case of previous cesarean section cases where we want to rule out a morbidly adherent placenta, and in case of chronicity determination. Those are the cases where you want to check the placenta. How do we do it? We can do it transabdominally or transvaginally. Transabdominally for high placentas, normally you position the probe in the sagittal plane on the suprapubic area with a slight tilt into the pelvis to visualize the blood and the cervix. This allows location of a low-lying placenta in this relation to the internal os. That is, if you want to see the extent of the placenta, this is the technique you have to employ. Then you slide the probe in transverse fashion along the abdomen to visualize the majority of the placentas, and posteriorly, or which are either posteriorly or anteriorly. If not, then you try to check the parasagittal. You try the parasagittal movements to localize lateral placentas. That is to locate the placenta. The transvaginal route, this is preferred if the placenta is low-lying. The moment you say the placenta is low-lying, the next stage now you want to do a transvaginal assessment. The transvaginal assessment is safe for placenta previa. So do not say I'm not going to do transvaginal assessment because the woman is bleeding. It's actually safe for a woman who is bleeding. And it is good to be precise with the low-lying placenta. Sagittal orientation of the probe without too much pressure on the cervix is required, and the bladder should be empty. Not 100% empty, you need probably a quarter full so that it can guide you in terms of where you should go. But it should not be done with a full bladder. So before you do TVS, kindly ask women to go and empty their bladder. Fortunately, most women cannot empty their bladder to 100%. So you will still have some bladder to see there. Very few can do it, but most women, whenever we ask them to go and empty their bladder, the time they come back, there will still be some urine there. So it does help. The fact that most women cannot, empty all of it, because if they empty all of the bladder, sometimes it's difficult for people to know where to position the probe. So that's the demonstration of an anterior placenta, how it looks. So you will see an abnormal thickening of the anterior wall, not abnormal, but a thickening of the anterior wall. That is how you identify the placenta. And normally it should be homogeneous in terms of appearance. As you can see here, most placentas which are not matured, they should show some homogeneous appearance because they are well perfused. But if once the placenta is matured, then you are going to get a lot of echogenic areas in it due to the infarction which will be setting in due to maturation of the placenta. The echogenic appearance can be either intraparenchymal or could be on the basement membrane here. So always check and see. The basement membrane calcification is normally a part of the normal aging, but the intraparenchymal calcification, normally they're not a good thing because they may affect the baby's growth. So these babies will need to be monitored with this kind of situation. This is a posterior placenta, anterior placenta there. Then in terms of the cervix, you can see here, this is a low-lying placenta, and this is the cervix. This is the bladder there, almost very empty bladder. You can see it here. You can see it here, the placenta, it's measured 17 millimeters away from the internal os. Then this is a low-lying placenta, but this placenta is posterior. This one is anterior, as you can see here demonstrated. And this is a posterior one. So the posterior placenta, you can see, is touching the os. In this case, this is placenta previa. The moment the placenta touches the os, it becomes placenta previa. I know for doctors, I think you were taught before that the placenta is partially covering and so forth and so forth. All that was done before the era of the ultrasound. In the era of ultrasound, as long as the placenta touches the cervix, it's placenta previa. There is no classification of major or minor because it doesn't affect how this pregnancy is going to be managed. What matters is to tell us by how many centimeters is it encroaching to the other side. But the definition of minor and major placenta previa is obsolete. It doesn't apply in modern medicine now. So I've just put here to show you that this is the old classification. Probably even midwives, you have this in your books, but this was done before the advent of ultrasound. Now with ultrasound, all you have is either a high placenta, a low-lying placenta. All these placentas are placenta previa. Because the internal os, when it is closed, is just a point. It's a point, as you can see there. So you cannot speak of something covering half a point. There's nothing like that. These definitions were done when people were looking at an open placenta. This is a woman who is already in labor now, where you put a speculum and shine a light and see that, there's something that looks like placenta tissue covering half of the bulging membrane. This is how these definitions were formed, right? That was before the advent of ultrasound, but we can't be in the habit of identifying placenta previas in labor. Placenta previas are identified prenatally where the cervix is still a point, and you can't say you've covered half a point. So this is why this definition is obsolete, and this is the new definition. Right, so here you can see placenta previa again. You can see this is the internal os, and this is the placenta tissue covering here. This is a low-lying placenta. You can see there's some distance between the internal os of 14 millimeters. It's not really seated. This is just the depressed anterior wall being depressed by the probe here. There's slightly too much pressure, but this placenta is not attached to this anterior wall you see there. So placenta examination, how do we examine? So first of all, we locate we say, is it a right, is it an anterior or posterior placenta? After that, we want to comment on the placenta appearance. A normal placenta should have a homogeneous echogenicity. That means it should look the same throughout. When you are saying homogeneous, means similar echogenicity. What is echogenicity? Echogenicity, that means its appearance on ultrasound, to make it simple. When you look at it on ultrasound, the way it is appearing on ultrasound, it should look the same throughout the placenta. The placenta should look the same. If it is slightly echogenic, the whole of this should be slightly echogenic. If it is less echogenic, the whole of it should be less echogenic. That means homogeneous, means similar or the same. Then in terms of placenta thickness, I'm demonstrating the measurements here. The thickness should be less than 4 millimeters. Then the retroplacenta space, it should be anechoic. Anechoic means it should be dark. I remember what we were saying about the returning echoes. We are saying there are no returning echoes coming from the fluid. What is the fluid here? The fluid in the retroplacenta is blood. So there is blood here in the retroplacenta. This is where the flooding occurs, and this is where the baby gets the food from. This flooding, which floods into the baby's vessels. So the retroplacenta space should look anechoic. You will see this better with posterior placenta than the anterior placentas. The reason why you don't see it in the anterior placenta is because your pressure, when you put pressure trying to scan, you are going to obliterate this space. Because this space is obliterable with pressure. Right. In terms of placenta grading, some of you have heard they are saying placenta grading, grade 1, grade 2, and so forth and so forth. So in terms of grading, first trimester, normally we say the placenta is grade 1. What you normally see in first trimester is some echogenic thickening, a rim of echogenic thickening on the front, or on the either front or back or side within the uterine wall. That's a grade we normally give to the placentas in the first trimester. Then in the second trimester, most placentas will show you a homogeneous appearance with moderate echogenicity, which is greater than the myometrium. So that's a grade 2. So there will be some moderate echogenicity within the placenta in grade 2. Then in third trimester, you may see loss of homogeneity and appearance of punctiform calcifications, and also the lacunas. The lacunas in the legs are probably more, the term is used interchangeably, but I think let's use the term leg, because lacuna has implications, especially when you speak of placenta previous. So you're going to see some anechoic space within the placenta, and you're going to see some punctiform calcifications. Punctiform means these calcifications are like dots, on the placenta, right? Like punctures, punctures kind of. So they look like dots. You see these little dots on the placenta forming. So this is what we would call a grade 3 placenta. This is the normal aging of the placenta, which is being mentioned here to say first, second, and third trimester. But with fetal growth restriction, this order can come earlier. You may see some placentas showing signs of aging in second trimester, giving a grade 3 placenta in third trimester. In second trimester. So look for these kind of punctiform calcifications when you scan patients. If it happens in third trimester, normally it's part of the aging of the placenta. The baby is growing well. But when you see them in second trimester, you know that the placenta is aged too soon, and this baby will need to be surveilled in the placenta disorder clinic. So that's the placenta. Then in terms of twins, chorionic determination, the best time to do is 11 to 14 weeks. That's the best time to do it. Then in late second trimester, we can use the number of placentas and also the fetal sex. Then sometimes we have a situation where we call indeterminate chorionicity. When we see patients very late, you rather assign them as MCDA, monochloride diamniotic, than anything else, so that we increase surveillance. The monochorionic monoamniotic, we look for condensations to try and answer to this question. And this is a fetal medicine unit diagnosis. I'll repeat this. This is a fetal medicine unit diagnosis. If you are working at a low-level center, please don't just say this is a monochloronic monoamniotic and attempt to manage the pregnancy. Refer to fetal medicine, because in most cases, the pregnancy labeled monochloronic monoamniotic are monochloronic diamniotic twins affected by TTTTS. but TTT is being missed there. And also the monochorionic monoamniotic pregnancies are extremely high risk pregnancies. They need to be managed in a fetal medicine unit. Then this is the placenta here. You can see the membranes. If you look carefully, you are going to see that we have this chorion tissue going in there. The chorion tissue means placenta tissue, right? Chorion placenta tissue. So this is placenta tissue going in there and forming part of the membrane. And you can see the amnion membrane separate here. So this is a dichorionic diamniotic. You see 3 membranes at least in this, because this is the other amnion there. Then in case of MCDA, there is no placenta tissue going in between. And what you are going to see are just 2 amnion membranes. So this is called a lambda sign on the left, and this is called a T sign on the right. But in reality, when you look carefully, you think this is the lambda sign. So the fathers who labeled this, I think we need to make them revise, because when you look carefully here, you can see that this one looks more lambda than the other. But anyway, this is the nomenclature recognized in the literature. The T sign is this one. So you see it here again, and the membrane appears thicker, but you don't want you to rely on the thickness of the membrane alone, because it's not a very reliable marker. And we see here the T sign. This one looks more T sign than the other one, but this is the MCDA to just illustrate chorionicity determination. Then placenta pathologies, placentomegaly. I've already mentioned that the placenta is abnormally thick. Then we have the placenta previous, then we have the placenta legs. These are the placenta legs down here. And of course, I don't know what this was. Probably it was what? A brucemo? Yeah. The amniotic fluid assessment. We do it as part of routine examination. In a high-risk pregnancies, such as preeclampsia, diabetes, and congenital fetal anomalies, amniotic fluid determination becomes very important, because the amniotic fluid is also a surrogate marker of placenta function. And it's also a marker of the fetus renal system. If there's something wrong with the baby's renal system, you may have an abnormal amniotic fluid. It is also important in cases where there's a rupture of membrane. Forgive the mistake, please. So when you are measuring amniotic fluid, there are 2 methods. We have the amniotic fluid index, then we have the single deepest pool index, then the experience performance assessment. So the amniotic fluid index was proposed by Felani in 1987, where he proposed that you can divide the abdomen into 4. But those who have scanned long enough, it's not in all situations where you can divide the abdomen into 4. This is the weakness of Felani's method. When the tummy is still below the umbilical cord, you can't divide the abdomen into 4. Or if it is just above the umbilical cord, it is extremely difficult to do it. So I want to assume that Felani devised this method because most women probably were scanned very late in 3rd trimester, and all the tummies were big enough to divide them into 4. So that's the weakness of Felani's method. But we want you to understand how it is done. So you divide it into 4 quadrants. Then in each quadrant, you look for the deepest pool and you add the pools together. You have to do it fast without putting too much pressure so that the fluid does not re-equilibrate itself before you finish. Because if you apply too much pressure and you do it slow, you may find yourself measuring the same fluid, which is just re-equilibrate itself because you are too slow to do it. So that's the challenge of Felani's method. That if not done carefully, you can remeasure and remeasure the same things. So when there is no fluid, you call it anhydramnios. When it is less than 5 centimeters oligohydramnios, between 5 to 25 normal, rather than 25 it is polyhydramnios. Make sure you are perpendicular to the surface, not to the woman's tummy. When you are saying to mean the horizontal, like the earth you are stepping on. So your probe should be perpendicular to the the ground you are stopping on, not to a woman's uterine contour, to the abdominal contour. That means you cannot do it on the woman's lateral side. You can't do it with you putting the woman's your probe on the woman's lateral side facing inside. The probe always has to be perpendicular to the surface when you are doing it. Please take note of this. Make sure that your measurement is not cutting across the baby's limbs or the baby's umbilical cords when you do it. Then we have the chambers method, which is the single deepest pool, which we use in the fetal medicine units. All you do is you look for the deepest pool within the uterus and you measure it. It's very simple. So make sure you lower down the gain so that you remove the fuzziness that is underneath the woman's uterus. This fuzziness, you clear it by lowering the gain so that you can see clearly. Once you've done that, you can take the measurements. The measurements less than 2 is oligohydramnios, between 2 to 8 is normal, and greater than 8 is polyhydramnios. That's the single deepest pool we use in the unit. We do it because it is easy. Yes, you can. There's a question whether we can do TVS on suspected threatened miscarriage. Yes, we do TVS on suspected threatened miscarriages. It's actually the indication for doing it. So please take note of this. Very good question you asked there, sister. So in special cases, like I've told you that before 20 weeks, you will find out that you can't do AFI. So this is where people improvise and do the right and the left deepest pool. But in our case, we just do the single deepest pool. Also, in the case of multiple pregnancies, you cannot do AFI in multiple pregnancies. So you do the single deepest pool. So you can see why we chose the single deepest pool, because of its easy practical applicability than the AFI. If everyone is able to just do the single deepest pool, they can examine twins, they can do what, but you can't do an AFI in twins. So remember this, and this is how the amniotic fluid changes with gestational age, the nomogram of amniotic fluid. It peaks around 32 weeks and begins to drop towards 10 as the placenta matures. So just be aware how amniotic fluid behaves, that in the beginning it's less but increases. So whenever we see patients at 32 weeks and we say the fluid is not consistent with the 20-weeker, it is because we know the nomogram, that at 32-weeker, this is where the baby should really have a lot of fluid around it. Right, so let's move on. Then in terms of amniotic fluid abnormalities, the oligohydramnios, polyhydramnios, you can see the single deepest pools here. Here, I did not cut across the probe here in my measurement, but I feel my measurement is too close to the umbilical cord. Probably I should have taken it somewhere here, but I cannot take a measurement here, cutting across the limbs here and the umbilical cords. You can't do that. So remember that. Cervical length. So screening for preterm birth is the indication, and also preterm labor, threatened miscarriage, and unpatterned hemorrhage. We do not do transabdominal assessment of the cervix. Our units do transvaginal assessment. This is what we teach. We believe is the most consistent and probably accurate method and more standard than any other form of assessment. So this is where we do not teach the transabdominal approach very much. So this is the cervix. So whenever you do it, make sure you identify where the bladder is, because you want to go to a place we call the utero-vesical fold. This is the utero-vesical fold because the bladder starts somewhere here, and this is where the cervix ends. So this is where you want to put the probe when you are doing transvaginal assessment. Don't apply pressure, too much pressure to the anterior wall of the cervix, because you will artificially lengthen the cervix length. So the pressure should not be too much. Just sit on it and you take you should make sure that you can see the canal throughout, and you take the measurement from the internal os to the external os. This is how the cervical length is done. The transabdominal technique which you don't teach, the bladder should be half empty, and you should go and put your probe sagittally on the suprapubic area and press a little bit to see the cervix. It's not the way we want to check the cervix. So I'll emphasize more on the transvaginal. And this is the nomogram for the cervix in pregnancy here. So you can see that the cervix shortens gradually towards 10. So it is normal to find some cervix which are probably just below 25 millimeters towards 10, because the cervix gradually shortens towards 10. But it is not normal at 22 weeks to find the cervix which is less than 25. So this is why we say the cervix is less than 25 millimeters. That cervix is abnormally short, is likely to lead to preterm birth. So just remember this. So I think I will skip this for the sake of time. Then cervical funneling. Cervical funneling is premature opening of the cervix. It may not have opened in full like you see on this ultrasound scan image here. So when the cervix is funneled, we do not measure the funnel, we measure the part which is not funneled. So as long as the part which is not funneled is more than 25 millimeters, the risk of preterm birth is low. But these women will need to be followed up in a preterm surveillance clinic. Then I've put this image here to also illustrate that the cervix is an upper part and a lower part. So whenever a stitch is being put, the idea is to be able to put it in between the upper and the lower part of the cervix so that it's equidistant here. If the stitch is put here too distal, this stitch is wrongly put, and you don't want to put it too much on the front as well. So this is where the stitch should be put. So when you are doing preterm surveillance clinic and assessing the stitch position, this is exactly what you are looking for, to say, has it been put in the correct position, the equidistance between the upper and the lower part of the cervix. So just to show you, this is an open cervix here, and this is a cervix which is funneled with only 6 millimeters of it left. All right, this will just demonstrate what checking the cervix transabdominally can do. This is a woman with a full bladder. If you do cervix with a full bladder, you are going to create an artificial funnel here, and you think the cervix is funneled, and you are also going to forcefully lengthen the cervix, because the bladder will press on the ischemic portion and make it longer here. Right. I think I'll stop here. The time is up. I don't want to continue beyond 9 o'clock. So I think next week, one of our registrars will present, but I will continue on the nobology next week and also play it for you, the videos. I think after this, these are the videos to just illustrate what they do. And because I know people have machines, sometimes you wonder, what are these buttons for? So on these videos, I'll be illustrating what all these buttons are, what are their functions. They are on every machine which you will come across, and what they do. So I will be doing that next week, including, I think these are the videos as well. I'll be going through the probe, tell you what the probes do in terms of what are these signs on the probe, what should you use them for, and also the scanning. We'll be doing scanning here to just show people how to do them. This is a basic scanning to show you what it does as we move the probe. You can see that as we move the probe, what do we see? What is this movement of the probe? All that. So I think I'll end here today. Next week, one of our registrars who is registered with us is going to present some cases. Then I'll continue this. Then I'll come back to finish the heart. After my presentations will be interrupted by any of you who is presenting. If anyone is an interesting case, don't hesitate to interrupt my presentation, because my presentations are just mere revisions. So thank you so much. Bye-bye. Mukala, these questions are addressed in another forum. You are asking about late onset FGR. Please attend the basic, the refresher course, Mukala, so that your questions can be answered. Thank